Okay, so a very warm welcome to everyone for our latest edition in the Colloquium series. Today, I have the pleasure of introducing Prof Naeemah Abrahams. She is the Director of the Gender and Health Research Unit of the South African Medical Research Council and has an honorary position as Professor within the Women's Health Research Unit at the University of Cape Town. She has worked in gender-based violence research for nearly 3 decades, focusing on the intersections between gender-based violence and health, the measurement of violence against women and children, femicide, and health impact of violence against women, including the interface with HIV and sexual and reproductive health. We also have joining us today Dr. Jani Nöthling. She is a postdoctoral fellow in the Gender and Health Research Unit at the South African Medical Research Council. She has a background in research psychology and completed a PhD in psychiatry at the University of Stellenbosch. Her research interests include childhood and adult trauma exposure, sexual violence, PTSD, and biomarkers of psychiatric disorders. She has worked on the RISE study together with Prof Abrahams, which is the study that they're going to be discussing with us today. So they've worked together on the study, and Dr. Nothling is currently working on a follow-up to the study, which aims to evaluate the feasibility of transdiagnostic group-based mental health interventions for women who have been raped. So without further ado, I would like to hand over to them to get going. I would ask everyone to kindly keep themselves muted. And I will open up for question and answers towards the end. And I encourage everyone to make full use of Prof. Abrahams and Dr. Nothling, who I'm sure are very excited and keen to hear from our presenters or from the people attending. Okay, so without further ado, please do take over.
Sheena, I'm just going to put up the slides and then Naeemah's going to start the presentation.
Right. I'm going to start. So good afternoon, everybody. Thank you for that introduction. And it is good to be in your company. I see a couple of familiar names, so thank you again. So what we're doing today, we have 1 hour. Jani and I will introduce the Rape Impact Cohort Evaluation Study. We will tell you, I will focus on telling you about the study background, and I will tell you about the main findings related to HIV. And Jani will tell you more about the mental health findings and our follow-up work. Okay, next slide, Jani. So like I said, next one. So like I said, our main reason for doing the RISE study was to look at HIV acquisition longitudinally after sexual assault, after rape in particular. We had a wide range of collaborators. You will notice Professor Cedar from the Anxiety and Stress Disorder Unit from the university is a collaborator, and obviously her expertise in PTSD was a very important part of the study. Next, please. So the background, really, I'm not going to go into detail because I think this is well known, that rape is a very, very common experience in South Africa. It is, and here our study focused on rape and not all other aspects of sexual assault, and mainly because of its links to HIV infection. We also know that rape and HIV have very similar drivers, and our interest was really to see, and there was very little knowledge about the health impact of rape. I was involved in the development of the burden of disease related to intimate partner violence and sexual violence. And the burden of disease group were very reluctant to recognize for example, that IPV was a risk factor for HIV. They said there was very little data and there was no longitudinal data to explain that relationship. So really that was the reason why I focused on looking at rape longitudinally. Next slide, please. So we're not going to look at this in great detail. When we started the project, we really started thinking about what are the different pathways to HIV after a rape. And we always think about immediate infection at the time of the rape event, and very often that does happen, but with PEP, that can be prevented if there's good adherence to PEP. But we hypothesize that most of the acquisition of HIV after rape was actually through mental health. And we knew, and we wanted to test this. And this is really why we developed this diagram to try and include all of these risk factors, or try and measure it as much as we can in the RISE study. Next one, Jani. So primarily, we wanted to look at HIV acquisition. In the period longitudinally, we were focusing on 12-month post-rape, and our secondary aims were related to PTSD. We also had women who were HIV positive in our study. We did not exclude them because we wanted to look at whether women who are HIV positive and experience a rape, how that rape experience impact on the adherence to medication and the health overall. Next one, Jani. So the study started in 2014. It was a longitudinal study. We ended on the eve of COVID in March 2020. We were extremely, extremely lucky that we had decided to end of March. The woman that entered the study, we had a minimum follow-up of 12 months, but there were many women that entered the study early, and we could follow them for up to 36 months. We did interviews every 3 months for the first year, and thereafter every 6 months. It was mainly face-to-face interviews. Well, it was all face-to-face interviews. We had many biological measures. I'll tell you a little bit about that. Our study had a trauma counselor who were part of the team. You can imagine doing a study following rape survivors is not easy. We had to focus on the retention. It was hard for the team. And sorry, can I just do a cough? I need to just do that. Sorry about that. I need to run for some water.
No problem at all. We all have our human moments, so that's absolutely fine. We'll just wait for Prof to return.
That's post-nasal drips. Thanks for allowing me to do that. So yeah, so I was telling you about vicarious trauma and the attention we had to give to make sure the team were able to cope with the stories that they heard, and that our participants were also supported. Next slide, Jani. So basically, we recruited women who reported a rape to a Tutuzela Care Center. The project was done in Durban. The difficult thing in the study was that we had to do the first interview within 20 days of the rape event. And this was because we wanted to make sure we measured HIV, we knew their status, and because of PTSD, we had to be able to document the anxieties, disorders at the time of the rape. Women were excluded if they were severely mentally traumatized or they had cognitive disabilities, and also if they were more than 14 weeks pregnant or lactating, breastfeeding. The woman, then we had a control group. The control group was women who had never experienced a rape. They were also women who were health-seeking, women who were using health services. And we focus on women that were attending family planning services because we wanted women who were sexually active. And they had the same set of exclusion as the rape-exposed women. So we often talk about rape-exposed women and and women that were not exposed to rape. Apologies for that. It's just a way to differentiate between the two groups. Next slide, Jani. This gives you an idea of the many outcomes that we measured. Biologically, we tested for HIV, for women who were positive. We tested CD4s and viral loads, STIs, pregnancy tests, diabetes. We did lipid panels. We checked their blood pressure. We included hair cortisol, and then we collected bloods for DNA epigenetics. And in fact, Jani did her PhD looking at the epigenetics of PTSD and changes in epigenetics in the period after rape. And then we did all the other stuff, such as child sexual violence experiences, intimate partner violence, non-partner violence. We asked them about rape stigma, health-seeking behavior. And for those who were HIV positive, we asked them about linkages to care. Now, the mental health was a long list. We used the the neuropsychiatric interview. I'm sure you're all very familiar with it. For depression, we used CSD. We used the Davidson Trauma Scale for PTSD. Life events checklist, childhood trauma, resilience, coping, and many other measures. So yeah, the women spend quite a bit of time doing it. We made sure that the experience was not stressful, and the environment was, we made it conducive to ensure that they, the experience were not additional. We weren't causing secondary trauma. Next one. So this is just a flow diagram of the two groups. On the left is the women who were from the TCCs. They were rape exposed, and in the light green were the women who were the controls. Basically, I wanted to show you that we had 1,019 HIV negative women, and you could see that the loss to follow-up were greater amongst the women who experienced the rape. But we adjusted for these in our analysis. Next slide. So I'm not going to give you the detail. We had great statisticians that helped us to do the analysis. I'm going to focus and just tell you about the HIV incidence that we focused on to look at the difference in HIV acquisition between the two groups. We used a multivariate Cox regression models. We did sensitivity analysis, and we had to control for a number of covariates to make sure that we, so that those confounders that could have contributed to HIV acquisition, we controlled for in our study. For example, having multiple partners, having involving transactional sex, these are all factors that may contribute to increased risk for HIV. Next slide, Jani. So this is the demographic details between the two groups. I think it's important to know that they were pretty similar for most most of the important socio-demographic characteristics. We did find that education level were pretty much the same. There was no difference between the two. The only difference was employment and the main source of income. And this we can explain. The women who came from the TCCs who were exposed to rape, a quarter of them were employed, and there was a lower level of employment amongst the controls. How do we explain that? We think obviously people who attend and report to TCCs are a certain group of women. We know that there are many, many other women that do not report their rape. And so maybe it is women who are better informed, they know there are services, and although the education levels were the same, we think that women might have had more information about TCCs through having been employed. The other is the child support grant. About a third of the women who were not raped were recipients of child support grant. So this is the woman, remember, they were available at the family planning clinics. They were not working maybe, and they were more easily accessible to come and join our study. And so that's why we see a higher number of women whose main source of income is child support grant in the control group compared to the rape-exposed women. Women were also more likely to be not to be in a relationship amongst the rape-exposed. We don't know. Remember, we did the interview within 20 days of the rape event. The other important factor for you to know is that we could not ask the woman about the rape event. It was under investigation. The NPA would not allow us to ask the woman about who raped her until the rape is closed, until the case is closed, or the woman have asked the NPA to close the case. Only then could we ask women about the rape event. So we don't really have information at baseline about who was the perpetrator, was there a weapon involved, where did it happen? None of the rape information we had. Next slide, Jani. So this is the main finding. The purple line, the top line, is the incidence of HIV. The bottom line, the orange dotted line, is the women who are our controls, and the purple line is the rape-exposed woman. At the bottom, you see the follow-up time, which is from 3 months we're showing you until 24 months, and the incidence is on the other axis. So here you can see that at 3 months, both groups had incidence of HIV, which was very similar. Now, if there was a concern, if HIV infection was happening because of the rape event, we should have seen a higher level of HIV at 3 months amongst the women who were recruited from the TCCs. But we don't. What we do see is from about 6 to 9 months, we see a steady increase in incidence. So this is why we, and overall the hazard ratio was a 60% increased likelihood of women who has been raped to acquire HIV after the rape incident compared to women who has never been raped. Next slide. So basically, the finding really tells us that there is definitely over time, longitudinally, there is an increased likelihood of HIV. We controlled for important variables, and I told you about that already, including sexual risky behavior. And we also added variables like whether they receive support and the level of stress and their resilience. This paper has been published and it is in AIDS, and if people want to read it in more detail. Next slide, please. Just watching the time. So we hypothesize what is happening longitudinally. Why is it, and I'm not going to take you through details. All I wanted to say, the orange risk factors are the ones we think and we hypothesize increases the risk for HIV, and the green ones are the protective ones. So we're asking, what is it that makes women who has been raped to change their risk behavior from about 6 months onwards? And really all we could think about was what has happened to women is mental health. Next one, next slide. So this is why our key messages from the study is that women have elevated risk for HIV. We've confirmed it. We hypothesize that it probably stems from the trauma of the rape, which normally women maybe get support in the initial phase, but then the trauma really sets in the period afterwards, and this increases the risk for risky behaviors. And I think this is my last slide, where we want to say that we obviously need to treat the psychological trauma, and we're not doing that adequately as part of HIV prevention for rape survivors. Next slide. And I think this is where I end, and I hand over to Jani to continue to tell you about the mental health findings that we found.
Thank you, Naeemah. Yeah, so I'll take you through the mental health findings from the RISE study, and then just do a brief overview of what we are planning in the follow-up study, which is called the RISE-2 study. So just basically the baseline mental health characteristics between rape-exposed women and unexposed women. We see higher scores of depression, PTSD, alcohol use, childhood trauma, higher number of lifetime traumas, higher perceived stress, and then slightly lower numbers for resilience and more or less equal numbers for social support. When we look at the lifetime direct trauma exposure, we see that the rape-exposed group in blue there has got much higher levels of lifetime trauma exposure, keeping in mind that some of these exposures might also be related to the rape. So much higher levels in the rape-exposed women for being abducted, being robbed with a weapon, witnessing the murder of a stranger. The unnatural death of a family or friend was more or less equal between the groups. Murder of a family or friend was slightly higher in rape-exposed. Being close to death, much higher rape-exposed. Serious injury, much higher. A civil unrest and imprisonment, we see more or less equal numbers there. Then for childhood trauma, we see slightly higher levels in the rape-exposed group for all types, which includes physical abuse, sexual abuse, emotional abuse, and neglect. Then if we look at self-reported depression incidents over the 24-month post-rape, we see that depression scores decrease over time, but nearly all rape-exposed women scored above the clinical cutoff for depression at baseline. And their scores stabilize around 6 months, but it remains very high still, between 45% and 50% of women remain above the cutoff at 24 months. For self-reported PTSD over the 24 months, more than 30% of women showed high levels of PTSD symptoms at baseline. And around 18% scored above cutoff for PTSD at 3 months. And then we see that stabilizing around 6 months. with about 12% of rape-exposed women scoring above cutoff, and that remains more or less the same up to 24 months. So the mini, as Naeemah mentioned, the mini international neuropsychiatric interview was administered by trained research staff who were quite decently trained in administering the mini, intensively trained. We didn't include all modules of the mini, but we looked at major depressive episode, PTSD, panic disorder, social anxiety disorder, agoraphobia, GAD, bulimia, and anorexia. For bulimia and anorexia, I'm not going to show you the graphs because we had very few people. For bulimia, only one person in the rape exposed and one person in the rape unexposed group met the criteria for bulimia, and no one met the criteria for anorexia. So in terms of major depressive episode, we see a very high prevalence at baseline, 38.5%, and then that slowly decreases and stabilizes around 9 months at 4.7%, and keeps that way around more or less around 4% up to 24 months. For PTSD, we see 9% at 3 months, which was the first time point where we could apply a diagnosis of PTSD. And then again, slowly decreases and sort of stabilizes around 9 months. And we see a drop again around 24 months to 2.1%. Panic disorder, 3.5% at 3 months, and then sort of stabilizes around between 6 months and 12 months at around 1.5%. For GAD, very few people, just about 2 in the rape exposed group that met criteria and 1 in the unexposed group. We only see that up to 9 months, and then at 12 months, no report. Social anxiety disorder, we see 0.9% there, and it sort of fluctuates over time into 1.5%, again, very low numbers. For agoraphobia, we see slightly higher numbers, 8% at 6 months, and then a decrease up to 24 months with 5.2%. Then for women with comorbidities, more than one disorder, at 6 months, the rape exposed group, we see 7.8% prevalence. At 9 months, 4.4, and then a decline to 24 months, 2.7. Right, so that was just a brief overview of the mental health trajectories. We did, as Naeemah mentioned, measure a lot of other things, and there's a couple of publications out there on the study protocol, the baseline factors, the HIV acquisition, rape stigma, then intimate partner violence and non-partner violence and hypertension, and some genetic and epigenetic and proteomic papers. We're also looking at a couple of other things at the moment, which includes depression and PTSD symptom trajectories over 2 years and the impact of early counseling. Also sexual re-victimization, so those who experience additional rapes in the follow-up period, the effect of childhood trauma on the acute PTSD response, and mental health pathways to adverse pregnancy outcomes, the prevalence of disorders and cardiometabolic risk factors in the rape group. So I'm just going to briefly tell you a little bit about one of the papers which was part of my PhD, in which we looked at psychological risk and protective factors affecting the symptom trajectory of PTSD post-rape. In this paper, we only looked up to 6 months, so we used baseline 3 months and 6 month time points. We used mixed linear regression models to determine if baseline age, employment, education, relationship status, HIV, childhood trauma, lifetime trauma, social support, perceived states, rape, stigma, alcohol use, depression, and resilience were predictors of PTSD scores over time. So we found that none of the socio-demographic factors or HIV, childhood trauma, lifetime trauma were significant predictors of PTSD. And neither were the other risk and predictive factors such as resilience, social support, stress, and alcohol use. We did find that higher baseline rape stigma scores predicted higher PTSD scores at 6 months post-rape, and that higher depression scores predicted higher PTSD scores at 3 months and 6 months. Then we plotted the effects in graphs. So the graph on the left, the time by depression graphs, we divided the baseline depression scores into quartiles. The red line is the upper depression quartile. The yellow line is the second highest. The dark green line, the second lowest, and the light green line, the second, the lowest. The gray dotted line is the cutoff for PTSD on the TTS. So we see that those falling in the fourth quartile for depression remain more or less above cutoff from baseline to 6 months for PTSD. Then again, looking at the quartiles for rape stigma by depression quartiles, with again the light green being the lowest depression quartile and the red the highest depression quartile. But here also dividing into stigma quartiles. So the dotted line is the first stigma quartile and the solid line the fourth one. We see that as we move from graph A to B to C to D, there's an increase in PTSD scores over time. With graph D, where we're looking at the fourth depression quartile and all stigma quartiles, they remain more or less above cutoff for the entire period up to 6 months. So the findings do support previous studies where an increase in baseline depression and rape stigma has a significant adverse effect on PTSD recovery following rape. Although some previous studies have found that some of the other risk and protective factors do also play a role. But I think we wonder if in that immediate period up to 6 months, the impact of the trauma might be so severe that the protective factors just don't have an influence yet, and that maybe after the 6 months they may start to impact on recoveries. And then ideally screening for depression and correcting stigmatizing views soon after the rape may have beneficial effects. Right, so that brings me to the second part, the RISE 2 project. So this was initiated by Naeemah, and I later joined. So I think the main question here was, we know that mental health can influence HIV acquisition, but what kind of support is there? And really there isn't much, and how can we support rape survivors in the future? So the RISE 2 study, the aim is to investigate the feasibility and acceptability of a combined pre-exposure prophylaxis or PrEP and STEP mental health intervention. The mental health intervention involves the self-help plus intervention, followed when needed by problem management plus, and looking at the impact of those in reducing medium to long-term acquisition among rape survivors. So the self-help plus and the problem management plus interventions were developed by the WHO. They're group-based interventions, they're transdiagnostic, they're lay counselor facilitated, and each of them consists of 5 sessions of 2 hours long. And these have been evaluated in low resource, high trauma settings in Uganda, Kenya, and Pakistan. And they have shown improvement in mental health indicators, in general, a reduction in psychological distress, as well as symptoms of PTSD, depression, and anxiety. So PrEP is a daily tablet of Truvada. It's recommended by the WHO for HIV prevention in vulnerable groups. It's currently distributed by the Department of Health in South Africa, but its distribution is still fairly limited, and when it is provided, the uptake is quite low. So why the combined support for rape survivors? Given the high risk of HIV in the aftermath of rape and poor mental health being a driver of HIV risk, we hope that providing rape survivors with this combination of psychological support and PrEP may reduce their risk of HIV and increase quality of life in general. So there's two phases to the study. The first phase is translation of the intervention materials into isiZulu and contextually adapting the intervention materials, and then testing the intervention with 20 women and collecting qualitative feedback on the content and delivery of the intervention to further adapt the material. Phase 1 has been completed. The translation and adaptation of the material was done. We did cognitive interviewing with 20 women on the concepts to make sure that we translated it and had the right concepts. Training of the facilitators took part over 2 weeks, and you've got some of the attendees of the trainees in the picture. Then 20 adult women were recruited from a local NGO. 10 participated in the Self-Help Plus intervention and 10 in PM Plus intervention. And we also tested our quantitative questionnaire that we'll be using in phase 2 with 100 Zulu-speaking women, and validated the questionnaire. So for phase 2, we're assessing the feasibility and acceptability of providing the adapted interventions with PrEP to rape-exposed women over a period of 6 months. We'll have 50 women in the intervention arm and 50 women in a waitlist control arm who will receive the intervention after 6 months. Both groups will be offered PrEP if they're HIV negative. We'll be collecting qualitative and quantitative data on the delivery of the intervention, the content, mental health, trauma exposure, and gender-based violence. So just to give you a brief overview of the interventions for Self-Help Plus, as I mentioned, transdiagnostic, not symptom-specific, but rather to enhance mental health in general. It's not intended to be used with participants at imminent risk for suicide, those with severe disorders such as psychosis, and those with intellectual disabilities. It's based on acceptance and commitment therapy, and it incorporates mindfulness and meaningful living despite adversity. The materials are designed for participants with low literacy, so there's lots of pictures in the materials, and it's predominantly audio based. So in our study, we're delivering in groups of between 12 and 15 people, facilitated, guided. We're looking at a task shifting approach where the facilitators follow a structured outline based on a Self-Help Plus manual. And it's delivered weekly on 5 consecutive weeks using audio recorded material and a workbook called Doing What Matters in Times of Stress. And the picture you see there is the Zulu translated version of the Doing What Matters in Times of Stress. So session 1 is grounding, and it involves bringing attention back to the present moment instead of being caught up by distressing emotions. And the pictures here are pictures that's been adapted from the book for our context. Then unhooking, so builds on the grounding skills, and it's used to identify difficult thoughts and feelings, and then using grounding, which involves some breathing exercises to unhook from these feelings. Session 3 is doing what matters, so identifying personal values and then behaving in a way which is in line with those values in order to reduce stress. Session 4 is being kind. So focus on kindness directed towards yourself and towards others, again in relation to reducing stress. Session 5 is making room, and here participants learn how to tolerate stress while still acting in a way that is consistent with their values. And we were quite lucky to have the South African storyteller Jani Nöthling record our adapted isiZulu contents, and she did that for us in a calm but quite lively voice, and we'll be using that in phase 2. So a brief overview of PM+, similar to SH+, also transdiagnostic and facilitator administered, also 5 modules and 5 sessions delivered in a group. But unlike Self-Help Plus, PM Plus is targeted towards symptoms of common mental health problems. So, for example, depression, anxiety, and grief, rather than just general promotion of mental health. The 5 modules are based on problem solving and cognitive behavioral treatment. And problem strategies are applied and developed towards the problems identified by the participants themselves. The modules include psychoeducation, stress management techniques, problem management techniques, and task-oriented activities, which are aimed at improving mood and functionality and strengthening social support. So the first session is understanding PM+ and managing stress. So here, just a general explanation of the intervention. Participants engage in group discussions. They're introduced to a case study, which is the story of Tandi, which you see on the right. They identify goals they would like to reach by participating in the intervention. Adversity is explained, and the effect of stress on the body is explained. Again, these are adapted images for our context. Then the next session is managing problems. Here they go through the list that you see on the right, and they list problems as solvable or not solvable. They choose a problem to focus on. They define the problem. They think about possible solutions to solve the influence the problem has on their life. They choose the best solution. They make an action plan, and they review how successful they think the action plan might be. The next session is get going, keep doing. So here a new strategy is introduced to deal with low mood and inactivity, and the inactivity cycle is explained. It focuses on activities that make you feel happy, relaxed, or content. And activities that's easy to do are introduced first. So, for example, going for a walk, taking a bath, listening to music, sitting in the sun. And then activities are divided up into single, easily manageable steps to encourage the implementation. The next session is focused on strengthening social support. So the role of social support in dealing with problems are explained, and reaching out is encouraged. Obstacles to strengthen social support are explored, and an action plan to strengthen social support is developed and broken down, again, into single manageable steps. The last session is staying well and looking forward. Here, the facilitators go through the PM+ strategies. They praise the participants for reaching their goals, and they encourage them to use the skills that they learned to solve problems they might still have or future problems that might arise. Right. So phase 2, it's currently underway. Consent and baseline interviews are being completed, and we hope to start the first intervention group within the next 2 weeks. We also plan on expanding the study to include 50 women from shelters and to investigate the feasibility of the study for use in populations with high exposure to intimate partner violence. And then just a thank you to the investigation team and the project coordinators and the field staff, and also the voice artist and the illustrator, and the SAMRC for funding the study, and for the WHO for their support and helping us with the materials. That's it from me.
Thank you. And a big thank you to you, Jani and Naeemah, for such a succinct overview of a clearly comprehensive body of research. I know from my side, it's personally quite nice to see research emanating from these contexts. So I have a little bit of background of working in public health in KZN and interfacing with the TCCs. So it's nice to see research emanating from these contexts. I wonder if you'd be able to share which 40 TCCs were involved in the primary study.
I don't know if we meant to keep it as a secret,
Okay.
but I think it's okay. We work very closely with the NPA, so it's Prince Masheni, Mahatma Gandhi, and RK Khan.
Okay. 2 out of 3 for me. I was involved.
Yeah,
so that's just nice to know.
Yeah, and the crisis center at Addington Hospital.
Thank you so much for that. Yeah, so very interesting and very just nice to see research coming from those contexts, having that background. So I'd like to open up to my colleagues for question and comments at this time. And feel free to also use the chat function if you'd prefer. Otherwise, you could just raise your hand and then unmute yourself when I've acknowledged you. Okay, I've got a comment in the chat. So it says, thank you for the presentation. Intuitively makes sense that depression and stigma that have a bearing on PTSD.
Thanks for that. Yeah. So I just want to say it was a rape stigma in particular that we looked at. And we've actually discovered that we probably need to do better at developing a rape stigma scale. When I developed this questionnaire, I borrowed a lot from HIV stigma scales. And I know I can see there's some people in the chat, in the room here, that knows the rape stigma scale way better than me. But yeah, so we really do need to work on that a bit better, really understand it. And it's probably one of the things we plan to do in the future once we get to do all the things, all the papers and analysis. It's a very, the RISE study's got a large data set, and there's so much more to explore. So we'll get to that. Yeah.
Whilst I'm waiting for my colleagues. Oh, okay, there we go. We've got Bronwyn.
Good afternoon, colleagues Naeemah and Jani, and thank you for this very comprehensive talk this afternoon, covering a massive amount of effort and work, and it's similarly to Sheena, you know, to be able to do this in the confines of a 1-hour presentation is not so easy. So thanks to both of you and for you know, presenting it in a way that is easily digestible for all of us. I can't recall now if it was you, Jani, or Naeemah who presented the slide on the prevalence for MDD at baseline, and then how that decreased over time, with that stark decrease from baseline to, I think, either 3 or 6 months. And I can't recall quite what some of the explanation for that decrease from baseline to 3 or 6 months was for the prevalence of MDD. And whether you would be able to reflect on how the nature of participating within this study, and given the various contact points for participants and the number of interviews done, whether you think that might also have any explanation as to some of the decrease of not only perhaps depression, but perhaps some of the other disorders that were screened for. Of course, you know, the nature of participation won't necessarily come across on meeting certain criteria, but I just thought by virtue of participating in the study, what sort of support that may offer for these women, given how quickly they were recruited after the rape.
So I think in general for sort of our main outcomes, PTSD and depression, we do see quite a dramatic drop from baseline to 3 months. And I think in general, that's sort of just a natural recovery period that we see. But also in terms of the amount of support they received, we did have a trauma counselor on the RISE site. And those, especially those who were flagged with suicide risk, were sent to the trauma counselor for debriefment, and they were offered follow-up sessions. In terms of the TCCs, some did have some counselling and follow-up sessions with the TCCs, but generally we don't see a whole lot of counselling there. So I think just being in contact with the team, and the team being quite supportive, definitely does play some role in reducing their symptoms, and especially with having a trauma counsellor present as well. And I think what we also saw is those with higher PTSD and depression symptoms were more likely to stay in the study, meaning that they probably got something from returning. I don't know, Naeemah, if you want to add anything to that.
Yeah, I think that was a very important question, Bronwyn. I don't know why I'm acting up again. Counselling. Women return for counselling to the TCCs. We don't know how often they went and how much they received. Sorry. Jani, do you want to explain the early counselling that we found in the depression and PTSD? The most recent paper?
Yeah, I'm trying to remember.
Analysis. Okay, I remember it. No, I know it. I'm busy with the paper. Okay, I've got it. So we looked at the trajectory of PTSD and depression over time for 24 months. And we also got information from the woman about whether they attended counselling at the TCCs. And we considered early counselling if they reported they've been to the TCCs to go back to the TCCs for counselling if they went there in the first 6 months. And we looked at whether that had a role in the PTSD and the depression over time, and we found nothing. We found that early counselling did not really impact on the trajectory. So what does that really mean? The thing is that we aren't sure. I mean, this is it's a bit of a political thing to say, but the counselling that they receive at the TCCs, it's voluntary. We know that initial one is about debriefing and containment, and the follow-up ones should really be the more longitudinal sessions. And what I hope is evidence-based, right? I don't know that. So we have just completed data collection of women, qualitative data on women who were in our group, who were in our rape exposed group. And so we've spoken to them now 3 years, well, study closed in 22. So we spoke to them last year or early this year. No, it's finished early this year. And they spoke to us about attending counselling and not attending counselling. And they spoke to us about why they're not attending counselling. And they also spoke about why they felt coming to the clinic, to our site, was for them more useful. It was, we were present, we engaged with them, And our counselor did not necessarily see all of them. So yes, we suspect our presence and having a safe environment for them to return, even though we ask them for bloods and for urine tests and all of that. But we also check their blood pressure. We did a pregnancy test. We did an HIV test. So women valued that. So we don't know about counseling, really what's happening. And so this is obviously why we're doing RISE 2, is to try and find something that lay counselors can deliver. And we know we're not going in to treat the PTSD and the depression. What we are hoping to do is to just help them to manage the stress. I'm not a clinical psychologist. I'm not, haven't got the expertise in psychiatry or anything like that. And so, so counseling for me is a big next area that we need to tackle, to know what works for women. I don't think we know for trauma. You know, we're a country with lots of trauma and we're not yet the experts in trauma. I think we are. There are many experts, but it's not getting to the woman and the people who needs the intervention. So yeah, so there's a big gap.
Okay, thank you so much for addressing that. Yeah, so that speaks to kind of a translation of what we know theoretically and into practice. That kind of gap is still there. I think we have a few minutes for any last question from anyone. No?
I apologize for my throat. It just acted up today.
No problem at all. I was just saying when you left is that we all have our human moments. So it's absolutely fine. Thank you both for your time and for engaging with us today. It was really lovely. Thank you everyone for joining as well. And the talk will be available on our YouTube channel thereafter. Thank you.
Thank you for the invitation.